Good morning. My name is Steve Kaplan. I'm a professor of urology at the Icahn School of Medicine at Mount Sinai. And my topic today will be the medical management of benign prostatic hyperplasia. So, when we talk about medical management, we have to keep a lot of things in mind. First, obviously, the symptom part that we now call LUTS or lower urinary tract symptoms secondary to benign prostatic hyperplasia. Sexual dysfunction, because a lot of the times this is concomitant with lower urinary tract symptoms, as well as potential side effects of medication. And clearly today, metabolic dysfunction is part and parcel of the process as well, particularly in an era of increasing obesity in the Western world. So, more specifically, we have to think about the epidemiology interconnections between LUTs and metabolic disorders, the pathophysiology and the interconnection between these three entities, and finally, some of the pharmacotherapies, which is what I'm going to be focusing on today. Now, lower urinary tract symptoms can definitely affect life. And for those of you who either have it, or for those of you who have treated it, or for those of you who have been exposed to it in family or friends, it does change people's behavior. So you can see from this graph here that you may limit fluid before travel or before bedtime. Certainly, if you're going to sit in the middle of a row of a theater where you would have to get up in the middle, you're going to limit the amount of fluid that you're going to actually go. And you can see that the interconnection between changing activity and having lower urinary tract symptoms secondary to BPH is very, very significant. So, male lower urinary tract symptoms, we have to really identify the patient profile. Who actually has BPH, who should be treated, and what is the optimal treatment for each patient. So, BPH is a big market. It's a big world. It's a big field, particularly because men and women are getting older. And you can see the projections of the amount of millions of people in the United States. It's estimated that there will be about 80 million above the age of 65 by the year 2050. And I think that's probably an underestimate. And even in men over 50, this could be something that could be an important area of therapy. And you can see from the graph on your side, in terms of the age structure, that there's going to be a market increase. And it's interesting, when this originally slide came up, they looked at 2020 and here we are, and you can see the vast increases in patients above the age of 55. There's an increase in nonagenarians and octogenarians, and this is the type of patients that we're going to be seeing to treat. And more specifically, this represents the population 65 and over that's projected between 2002 and 2050, with as many as 86.7. And I would argue that there's probably going to be more above the age of 65. So the prevalence of BPH does certainly increases with age, with a corresponding increase in medical and surgical therapies. And now, in an era of minimally invasive therapies, this is going up even more. Now, this represents patients who we may wind up seeing, but a lot of patients don't even actually present to the healthcare professional's offices. They're self-managing, as we'll talk about a little bit later. So the pathophysiology of lower urinary tract symptoms is related to a lot of different things. There is aging, there are vascular and neurogenic issues related to OAB, or overactive bladder, secondary to increased outlet resistance, increased workload, which creates a thickening of the bladder, detrusor overactivity, poor compliance, decreased volume, and increased tone. Of interest, about 60% of men who have some degree of obstruction secondary to an enlarged prostate also have overactive bladder symptoms. And that's another target that we can actually be looking at. So finally, you can have muscle decompensation with a lot of these types of symptoms that actually occur. But let's not rule out the vascular factors, neuroreceptor issues, and increased tone of response. Remember that these are now targets for treating the lower urinary tract symptoms. This represents guidelines from the AUA. This is from 2011. And as a heads up, we are currently again meeting to update the medical guidelines for BPH, but most of my recommendations will come from either a constellation of the previous guidelines in 2011 and other guidelines throughout the world. And it's kind of a full slide, but the point is that you need a good workup for the patient. You need to offer and evaluate the particular symptom load of the patients and concomitant problems, and then determine what the next best steps are. It's not one step fits all. And in fact, precision medicine really has a role here in treating BPH. So, for example, the recommended tests are usually related to an international prostate symptom score or some symptom measurement. We also use a frequency volume chart in patients who have a lot of those types of symptoms, flow rate, residual, pressure flow studies potentially. And if they have predominant overactive symptoms, overactive bladder symptoms, we can certainly initiate things like lifestyle intervention, behavioral therapy, perhaps antimuscarinics, which are now part of most guidelines as well. But if somebody's drinking 7 Starbucks Frappuccinos at night, no medication is going to change that. So we also have to make sure that patients understand the concept of the role of fluid intake, caffeine, alcohol, etc., in terms of managing this. And this is kind of a more of a magnified in terms of some of the things that we should be looking at. And then if they fail these, we can reconsider some of these type of other symptoms. And you notice that I mix bladder outlet obstruction and overactive bladder in terms of targets for therapy. And I do that on purpose because that gives us sort of a headwinds in terms of what the next steps should actually be. And let's not, again, underemphasize the importance of how behavioral therapies, behavior can actually change and the role that it actually has. These are some of the now other types of therapies. If we have what we think is evidence of bladder outlet obstruction, we first usually will offer medical therapy and gear it towards either the outlet obstruction type of symptoms or the overactive bladder combination. And we'll get specifically in some of these medications in just a minute. So this has been the evolution of medical therapy. First, there were the alpha blockers, the 5-alpha reductase inhibitors, then the antimuscarinics, PD5 inhibitors. And when I say other drugs, there are other targets, but also combinations of these. These include the beta-3 agonists, which I'll talk about a little bit later. So there's certainly a constellation of medications that have existed and have been developed over the past actually 30 years, and it gives patients and therefore their healthcare providers a lot of opportunities. Now, there's a lot of conditions or diseases behind these symptoms, and these come from the management of male LUTs from the EAU. And you can see that the lower urinary tract symptoms is kind of the symptoms that we talk about, but it's related to a lot of different things, including tumors, bladder stones, urinary tract infection. But again, the most common ones would be benign prostatic enlargement and overactive bladder type of symptoms. So these are the pharmacologic options. If we target the bladder, it's usually going to be the antimuscarinics or the beta-3 agonists, and they're really geared towards predominant storage symptoms, frequency, urgency, urgent continence. PD5 inhibitors, and I put them in the middle because we don't know exactly where they work or if they work or where they're targeted. And finally, targeting the prostate, and those would be the alpha blockers or the 5-ARIs. And again, this gives kind of an overview of what the rest of the talk is actually going to be about. Now, this again represents the EAU guideline approach, which is very, very similar, but the concept of emphasizing education and lifestyle, very, very important, but yet the same choices of medications. We'll talk a little bit about desmopressin for patients with predominant nocturia. So let's get into the specifics. So the first medications that were really studied were the alpha blockers, as long as 1976 with Mark O'Kane, and then followed the seminal works of Roger Kirby and Herb Lepore, looking at drugs like doxazosin and terazosin. And they were designed to treat the symptoms of BPH. They were first studied in the 80s and got their regulatory approval in the 1990s. It is the most commonly used and effective therapy for treating BPH, symptoms secondary to BPH, does prevent clinical progression of BPH, as we saw from the MTOPS trial. They are effective, they are well tolerated, and now, certainly in the advent of generic therapy, reduce the overall cost. They are the first-line drug treatment in male LUTs. There's a host of them, alfuzosin in the United States, alfuzosin, doxazosin, tamsulosin, terazosin, and silodosin. There's a range of formulations. I believe that we can say, as we can for other medications, that the effectiveness of these medications are pretty similar. It's the side effect profile that's a little bit different. So I'm showing you here some slides. This comes from data from Perry and Ryan, looking at a typical alpha blocker improvement This is with tamsulosin, and the IPSS improves about 4 to 5 points compared to placebo, which is about 2.2 points. So a net of about 1 to 3 IPSS units. The flow rate improvement anywhere from half a milliliter per second to 1.5, with the net improvement about 1. So the effects are modest. So in terms of putting this together, this is something that you're going to actually see with virtually all the drugs, but I'm just showing you a typical one. So if we would look at all the alpha blockers, the total IPSS reduction is about 35 to 40%, flow rate improvement about 20 to 25% increase. They do work quickly. They have no effect on prostate volume, and the long-term risk of retention or BPH-related surgery is not really affected by alpha blockers. They relieve voiding and storage symptoms. You can see here a very nice slide adapted from Carabrook and Chappell, looking at the improvement of alpha blockers to relieve both the voiding and storage component. Obviously, it will relieve the voiding component more numerically because there are more questions. There are 4 questions for voiding in the IPSS and 3 for storage. The long-term efficacy in patients who do respond, both storage and voiding symptoms remain improved, but a lot of compliance issues do exist with medications, albeit, interestingly enough, with alpha blockers, there seems to be relatively good compliance because patients notice when they go off of it. Now, this is kind of a meta-analysis, if you will, of monotherapies for alpha blockers, looking at drugs like alfuzacin, tamsulosin, various studies, and what you see is a tremendous consistency in the change of symptoms and change of flow rate. And the level of evidence is pretty high. And I think we kind of know what alpha blockers do, what they don't do. The recommendations by the EAU, and I would argue that that's very similar to what the AUA is, they should be offered to men with moderate to severe symptoms, and they're considered to be the first-line drug treatment in patients with moderate to severe LUTS. The next major class of drugs were the 5-alpha reductase inhibitors. Finasteride was the first one that was actually analyzed and FDA approved in the 1990s. It does reduce prostate size, and in selected patients and properly selected patients may actually reduce symptoms and improve flow rate. They do regulate prostate growth and BPH development. There are 2 that are out there, dutasteride and finasteride. The major difference is dutasteride is both a type 1 and type 2 inhibitor, and finasteride is just a type 2. The half-life of dutasteride is about 35 days, for finasteride less than half a day. The percent reduction of DHT is much higher with dutasteride, but in clinical studies, as I'll show you, there's not much difference in terms of efficacy. So overall, it's a very good drug in patients with large prostates. How we define large prostates is variable. They exert an androgen effect on the prostate by inhibiting the 5-alpha reductase enzyme. They do decrease DHT concentrations, slightly increase testosterone concentrations, and you can see here the difference in half-life. I'm going to show you the dutasteride reducing side, and the dutasteride studies were very, very interesting because they learned from the finasteride experience that you're really not going to have much of effect in patients with 30-gram prostates or less. So they did their studies in patients with 30-gram prostates or more, which is why they appeared numerically and statistically to have a more profound effect, although in head-to-head studies it seemed to be pretty similar. So you can see here that in terms of change in prostate volume, it's as high as 27%. And I think we see that there can be anywhere from 20 to 25% reduction in prostate volume with 5-ARIs. And frankly, that is true also that we've seen that with finasteride. They do reduce symptoms, and this is in the double-blind phase, is about 4.4 points. Placebo is about a point or 2, so it's probably a net of 1. And in the open, it was about 6.5. And you say, well, why did they get better? Well, these are the patients who responded. So you're getting the best of the best. So in patients with large prostates, can you see significant symptom reduction? The answer is yes, but you also have to compare it to placebo. And again, to emphasize that the dutasteride studies appear to show a better effect than finasteride, but that is because they were, I think, prescient in their studies by only doing it in men with prostates 30 grams or greater. 5-ARI should be considered in men with bothersome LUTs and an enlarged prostate. And you can see that there's a much more modest effect of improvement in IPSS and flow rate. They do decrease prostate volume. They do have an effect on AUR and BPH-related surgery, but they don't work right away. And I wouldn't say, we always say about 6 to 12 months. We can't see efficacy, or I should say effect, certainly sooner, but we don't consider a full evaluation of the drug until patients are at least on it for 6 to 12 months. They're observed after this type of minimum therapy. IPSS is reduced by about 50 to 30%, and symptom reductions dependent on prostate size at treatment. We have a general idea that we'd like to see a prostate volume probably over 40 grams, and which may be a PSA of greater than 1.3, grade 1.5 or so, because that may be a proxy for prostate size. But this is becoming an area that we're trying to get greater definition on. Symptom reduction depends on baseline prostate volumes. You can see in some of the other data, really higher prostate volumes and sizes, you can see a more immediate effect. But in general, you can see effects even with smaller volumes as represented by smaller PSAs. Again, this represents some data from various studies, including the VA cooperative study, the combat trial, as well as MTOPS, very, very similar in terms of IPSS and flow rate improvement. And that's the beauty of it in terms of analyzing all these studies. You can see that within drug classes, it's pretty similar. Now, this represents the combination of medications, and this is the MTOPS trial. And you can see that, at least for an alpha blocker, that doxazosin was superior in terms of symptom progression prevention than finasteride, is represented here by the green. Doxazosin is the yellow. So, which makes sense because it's a symptom thing. But overall, medications can change the progression arc, but it's best represented by combination, as represented by the red bar here, which I'll talk about in a few moments. Finasteride, in terms of progression, is much better to prevent the progression as defined by acute urinary retention or the need for surgery. So it depends how we define progression. But again, it is certainly better than placebo. And once again, you see here the effects of BPH invasive therapy prevention with the finasteride really driving that engine for the combination arm. So again, alpha blockers is represented by doxazosin, probably a little bit better on symptom progression. 5-ARI is represented here by finasteride, better on the incidence of acute urinary retention and the need for surgery. Now, combination capitalize, in a sense, on both. So you get the goodies of both, but you also get the side effects of both. So they work faster, do shrink the prostate, but as I'll talk about in a few minutes, you do also have increased side effects. This represents the combat trial, which used tamsulosin and dutasteride as opposed to the drugs in the MTOPS trial. And the green represents tamsulosin, the orange represents dutasteride, and the orange represents the combination. Now, there was no placebo arm here. So that was one of the weaknesses of the study. But you see a lot of interesting things. First, if looking at IPSS, it took 15 months for the dutasteride arm to meet the effects of the alpha blocker arm. So you can see that this is a much slower effect than you see with the alpha blocker. Obviously, combination gets the goodies of both. And then it took up 18 months for it to surpass it. So that re-emphasizes that dutasteride or the 5-ARIs take longer. Combination of both work best. Now, the improvement is pretty similar to what we saw in MTOPS. In MTOPS, it was about 7 points, the combination, the improvement in IPSS, with the placebo being about 4 points. So again, keep this in mind when you do comparative type of analysis. There have been a lot of very good studies. The seminal combination studies were the Lepore study, which was the VA cooperative study, which was a year. The MTOPS, which had data for as long as 7 years, but was 4 years, and the combat trial, which was also 4 years. And again, the similarity in symptom improvement, flow rate improvement, and PVR was very, very similar. And I think we can say that dutasteride and finasteride were equally effective. This again represents the combat trial, looking the difference being that it had a placebo arm. Now, the risk reduction of disease progression was dependent on prostate size, and you can see that it was much higher for patients who had greater than a 40 cc prostate, a proxy being the PSA more than 3 or greater than 3. But prostate volume really drove this engine. There wasn't statistical difference based on age, baseline BMI, baseline IPSS, and frankly, even baseline PSA. But you can see what volume really did. It really drove that engine. And always remember that the bigger the prostate, the more likely that a 5-ARI will have an effect. If you look at the risk for AUR or surgery risk, and again, this comes from the combat trial, once again, in patients, let's just look at 40 to 60. You can see how it's driving up. But when you get more than 80, that's when it's really driven, the stratification of baseline risk for retention or surgery. Now, remember, it's not going to be much of an effect with an alpha blocker, although it can help in the very large prostates. You begin to see this effect even at lower volumes of 30 to 40, and here with dutasteride alone in volumes of greater than 80. So remember that volume is going to be a big deal here. Now, you get the goodies when you combine the two drugs, but you also get increased rates of side effects. So erectile dysfunction is higher in the combination, dizziness, postural hypotension, asthenia, decreased libido, and abnormal ejaculation. So you will get the combination of these types of side effects. Same thing we see here with the combat trial, much higher, particularly the ejaculation and erectile dysfunction with either arm alone. So the EAU recommends 5 ARIs, and the AUA will be very similar with men to moderate to severe LUTS and enlarged prostate. And the combination should be offered to men with moderate to severe LUTS, enlarged prostates, and reduced flow. And I think that is probably what goes on throughout the world. Now let's turn from prostate drugs, if you will, to bladder drugs. And the muscarinic receptor antagonists work specifically there. And there are a host of receptors, M2s and M3s, and those predominant in the bladder, with only M3 being involved in bladder contractility. But because you have multiple areas where these works, this can explain why these drugs work, but some of the side effects, including dry mouth and constipation, that you can get with these drugs as well. So this represents data using solifenacin or Vesicare, and specifically on the mean change in baseline on urgency episodes, incontinence episodes, and micturitions is better with solifenacin, either the 5 or 10 milligrams. Now remember, look at the parameters we're looking at. We used to look at IPSS. Well, these drugs didn't really look at IPSS because they were being studied for overactive bladder, which uses frequency urgency types of evaluations as opposed to the typical BPH evaluation. Nevertheless, patients don't care what you call it. They still have urgency and frequency and potential urgent incontinence. So we can see where these drugs may actually have an effect. Now, this is antimuscarinics only in males, and I was involved in a lot of those studies with tolterodine and fesoterodine, and this represents drugs of various types, including some of the antimuscarinics I mentioned. And the frequency and nocturia, again, pretty similar. Urgent incontinence, pretty similar. The IPSS improvement is also pretty similar, although it's a secondary metric. Now, the concern about using antimuscarinics is the increase potentially in PVR, because these drugs decrease either sensation or contractility. But overall, actually, numerically, they certainly do. And you can see actually even a 22 milliliter per sec, a 22 mil increase in residual, but the rates of retention is about 1%. And frankly, that's the rates of retention in the natural population. So I'm not sure that the medication really adds that. That being said, PVR should at least be followed initially in men who are given antimuscarinic therapy. Mirabegron, and that's a beta-3, and there's been a lot of data on beta-3s. The original data obviously was an overactive bladder with some good data in men. And we were involved and presented last year the PLUS study, which was using mirabegron in men who had failed tamsulosin therapy. So they were randomized to either get tamsulosin and placebo or tamsulosin and mirabegron. And that's reality, because in the real world, most patients are put on an alpha blocker, and if they have persistent symptoms, are given either an antimuscarinic or, in this case, a beta 3. And it did meet primary endpoint by changing the number of micturitions. And you can see here in the tamsulosin mirabegron group versus the placebo. And I think this shows again that in patients who fail monotherapy or not having the complete response you want from monotherapy, a combination can be very, very effective. I'll talk briefly about desmopressin, and unfortunately, there have been a lot of more recent desmopressins which have not really been able to change the markets because I think they've had tremendous value in proper patients. Because if patients have pure nocturia, you should look for the etiology. It's usually going to be nocturnal polyuria, and that can come from various factors, including sleep apnea. But desmopressin is a beautiful drug to use here. The problem is the concerns about dilutional hyponatremia. So you have to be very careful, particularly in the older population. But in patients who have almost pure nocturia, desmopressin should be something that is thought of in the background as well. And the efficacy is actually pretty good. There's a lot of formulations of it, and we've begun to use a little bit more in patients with pure nocturia. And again, that's secondary to nocturnal polyuria, but you got to be careful, particularly with the current formulations, and monitor patients' sodium. The adverse events, is what I discussed, include headache, nausea, diarrhea, abdominal pain, but again, be very careful of the issues of delusional hyponatremia. Now, the most commonly used therapies are actually plant extracts. It's an over $25 billion a year industry in the United States, and there's a lot of information and a lot of data. And in the one trial that actually used placebo, we found that there was actually no difference between saw palmetto and its formulations and placebo. And I think that's really the take-home message. Now, patients always ask me, well, can I take it? Is it, and is it benefit? And I usually sort of half jokingly say the people who benefit from plant extracts are the people who sell it to you. And the other part that I say is the patients who benefit the most don't need anything. So if patients have minor symptoms, virtually anything is going to work. But patients with more moderate to severe symptoms, we don't really expect as much of an effect. They are very heterogeneous, different concentrations, but in general, we do not believe that these medications are really effective. PD5 inhibitors. PD5 inhibitors, specifically tadalafil, have been used to treat the symptoms of BPH either alone or in combination with an alpha blocker. While all these drugs were studied, tadalafil or Cialis was the only approved one, and it has shown efficacy compared to placebo, and both either in combination or as a monotherapy. We did our own study using alfuzosin and sildenafil. The question is, we've never found a mechanism of action. Here's a combination study, and in this, you can see the improvement using the combination of tadalafil and tamsulosin compared to placebo. Part of the problem is, in general, there's been no improvement in flow rate with tadalafil. This was one of the only studies that did show a flow rate improvement. And tadalafil remains the only drug that is approved to treat the symptoms of BPH. It doesn't improve flow rate. So I've always wondered about whether or not and why this drug actually doesn't work, or does it work really in the prostate. The most typical side effects are headache, flushing, dizziness, dyspepsia, nasal congestion, myalgia, hypotension, etc. It's contraindicated in men with some of these medications and should be used carefully with an alpha blocker because they should be separated by 4 hours. This is a tadalafil 5 milligram dose study, and this is the regulatory work. And clearly, numerically, compared to placebo, you do see an effect. There's no question about that. But the question is, why doesn't it improve flow rate? So tadalafil improves IPSS irrespective of ED. But it's very interesting that when they look at this, it's asked in patients with or without ED. And that may not be the best way to evaluate this, because there are men who believe they don't have ED who do benefit from a PD5 inhibitor. So again, this represents the data from Rareborn in patients with no ED history and those with ED history and sexually active, and the various types of doses. But ED versus no ED is not a useful proxy. I would argue that IEF scores were actually needed. So does improvement in sexual function influence the patient perception of changes in IPSS? Stated another way, do patients who are given a placebo on the tadalafil arm know that they're not on the medication, uh, but because of their erectile function gets better, they know that they're on the drug. So this is truly a double-blinded study, because one could argue that men in their 50s, if they take a PD-5 inhibitor, their erections will get better, even if they are sexually active and don't complain of ED. And there are patients who clearly have improvement in erectile function with these varying dosages. So they know they're on tadalafil, and it may have been an unintentional unblinding. Now, how do I know this is right? This represents a study that looked at men who said they had no ED, and they were randomized to sildenafil and placebo. And guess what? Men who had no ED still got better on sildenafil. So the no ED versus ED may not be the best proxy. And in my mind, I'm not sure that these drugs actually work in the prostate. They do seem to have effect a little bit on the bladder, on urgency, but I've always questioned the efficacy of these drugs in BPH. So, as I said, normal men who are unblinded, they knew they were taking tadalafil. So I think the mechanism of action is well defined for alpha blockers. There's no widely accepted mechanism of action for PD5s, lots of theories, and I think each of you will go from your own experience. So now let's turn to, finally, why do patients fail medical therapy? Well, symptoms are not relieved, maybe because all alpha blockers are not the same, differences among the 5-ARIs, the antimuscarinics, intolerable side effects, or BPH progression. They're getting worse. And those are the two most common reasons. And those are the urologic things that we actually talk about. Again, this represents, as I showed you before, the MTOPS adverse events, and they're significant. And a lot of patients, they may have an effect, but they don't tolerate these side effects. Again, this is the combat trial adverse experiences. And a lot of men complain about the ejaculation dysfunction and the erectile dysfunction as well. But the focus has always been on BPH and bladder issues, bladder failure, delaying missed surgery. But there's emerging data on long-term consequences, including dementia, depression, suicide risk. I want to share them with you. In medical treatment failure, there really are no rules. There's no widely accepted criteria. They've always been urology focused, and I think we need to look at other things as well. So let me just show you some data here on the 5-alpha reductase inhibitors. There's a hypothetical link between 5-ARIs and depression, the role of 5-ARIs in the synthesis of endogenous regulating neuroactive steroids, which may modulate stress response. Dysregulation can lead to depression. And there is some data. Comes from looking at the PCPT trial, which looked at cancer and the linkage data between Medicare claims. There was a 10% higher rate of depression claims in patients on 5-ARIs. In a JAMA study, this was a population-based study of more than 93,000 Canadian men using either finasteride or dutasteride. The mean age was 75. Suicide attempts significantly elevated until 18 months of follow-up. So again, we're beginning to get hints that these drugs may have an effect. Depression and self-harm were increased. In a Polish study of 4,035 men, there was a 1.5-fold increased rate of depression. Now, some of these were younger men and who were using these drugs for alopecia, specifically finasteride, and they may have a different psychosocial set and maybe a greater risk for depression, but men on the BPH age may not. In former users of finasteride, there's something called the post-finasteride syndrome. Again, younger men, higher rates of depression and suicide. Again, a different study, but at least points to potential risks with long-term 5-alpha reductase inhibitors. Now, those are some of the data that suggest that there is a problem. This study came out a few months ago from the National Veterans Health Administration of more than 50,000 males who were started 5-alpha reductase in 2014, and then looked at the ratio of incident depression and after using a 5-alpha reductase inhibitor, and there's no difference pre or post. The challenges were they were virtually all on finasteride, so we don't know what the effects of dutasteride are. Most of them were Caucasian, as unfortunately most of these studies are, and only about 60% were followed who had a treatment for more than 270 days. That being said, I would say at this point, we're not sure It is a conversation that you may engage with in patients who you think are at greater risk, but again points out to thinking about the long-term issues with some of these agents. There is challenges in analyzing these data. How do you assess depression, medication duration, controls? The overall summary suggests a possibility of 5-ARI use and decreased cognitive function, and I believe it should be part of the shared decision-making discussion in patients who you think are at risk, and we'll hopefully get some answers in the future. Now, tamsulosin also had some data. This came out from the University of Connecticut, looking at tamsulosin patients, and that men taking tamsulosin were matched at a 1-to-1 ratio using propensity scores, and compared that to men with no BPH medication, dutasteride and finasteride, and it demonstrated an increased incidence of dementia. And this created a lot of havoc because obviously tamsulosin is a very commonly used medication. And there have been other studies to suggest that this may not be true. This study, which I actually wrote an editorial for in the Journal of Urology from the National Health Insurance Service database from Korea, of almost 60,000 men above 70, with tamsulosin being compared to other alpha blockers, and there was no increase in the rates of dementia with a mean follow-up of about 5 years or so. And as I said, there was no significant difference compared to the other alpha blockers. Finally, anticholinergics and dementia, and this is a clear association in the Beer classification as well, particularly with using oxybutynin. We have to be very, very careful with long-term use of particularly that antimuscarinic in the types of patients we're going to be looking at. This assessed the association between anticholinergics and the risk of dementia in 55 years or older. Obviously, a lot of cases, almost 300,000 cases, 63% were women. The odds ratio was significant for patients taking these anticholinergics, and specifically, I would argue, oxybutynin with a 10.3% attributable rate. So we got to be really careful using these drugs in a long term, particularly bladder antimuscarinics. So finally, in closing, which agent do we use? Well, there's lots of factors. There are specific findings that assessed during the evaluation, treatment preferences of the individual patient, ability of the treatment modality to change assessed findings, and the key points to remember are the criteria are arbitrary and not well defined. Is it enough if the patient is happy? Well, that may be enough, but there may be some objective findings. Does medical therapy make sense for a quality of life condition? In a BPH world where missed surgery are improving, does medical therapy make sense? And again, it's beyond the scope of my talk here, but really we have to think where medications fit, certainly in the long term, and depends on the age of the patient. And certainly now, as someone who's becoming more of BPH age, I wonder if I would take long-term medical therapy. But certainly it remains the first treatment of choice, and we need to define medical failure. So finally, in closing, I'd like to leave you with this quote from Dean Orwish, that no one has a monopoly on truth, and science continues to advance. Yesterday's heresies may be tomorrow's conventional wisdom. When I started my practice, the thought of using medications for BPH was considered to be crazy and not going to be able to be done. And now that is the standard of care. So let's keep the research moving. Let's get a better handle on which patients benefit from which type of therapies and ultimately deliver the best type of care to our patients. Thank you very much for your attention.